Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, a comprehensive chat from the Islamic Medical Association, health professionals trying to serve Allah through service to mankind. And this is one platform where we trying to empower you, the public, through an educational forum. Alhamdulillah, alhamdulillah Rabbil Alameen, wal aqibatu lil muttaqeen, as-salatu was-salamu ala ashrafil mursaleen, Sayyidina Muhammadu wa alihi wa ashabi ajma'een. Tonight we've got a topic on gynecology, a very interesting discussion we anticipate, and the lines will be open shortly. We have our guest today, Dr. Taheera Hassim, specialist obstetrician gynecologist in private practice. Welcome to the show, Taheera. Assalamu alaikum.
Wa alaikum salam.
Before we start, I just want to quote an ayah from Surah Nisa, which is the 4th surah. Not to forget that while we'll be talking about physical ailments, Allah has given us comprehensive program and a comprehensive idea about how to treat women and the role of women in the world and as mankind. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس اتقوا ربكم الذي خلقكم من نفس واحدة وخلق منها زوجها وبث منها رجالا كثيرا ونساء واتقوا الله الذي تساءلون به والأرحام إن الله كان عليكم رقيبا. O mankind, fear your Lord, who created you from one soul and created from it its mate and dispersed from both of them many men and women. And fear Allah, through whom you ask one another and the wombs. Indeed, Allah is ever over you an observer. Sadaqallahu al-Azim. Taheera, basically gynecology is a very, very vast topic. Obviously, we won't be able to cover many areas of interest, but one of the things that has come to us as GPs frequently, and I'm sure you encounter, especially from the Muslim public and the younger ladies when they come into you for their first consultation as a gynecologist, is menstrual disorders and things related to the menstrual cycle. Perhaps we can introduce the topic by just having a brief discussion, and then the lines will be opened after that.
Okay. It's very common in my practice that I see young women with heavy menstrual bleeding or irregular cycles. The most common issues that arrive at the rooms is the young lady who's just started her period and now the cycles are irregular. So mothers are often quite concerned as to whether this is a problem. Usually in the first 2 years of starting your menstrual cycle, the cycles are often irregular. At times you may have 2 cycles within a month, and sometimes they may even miss a cycle. That's absolutely normal. After the first 2 years of starting your cycles, if your periods are irregular or you have excessive bleeding, then that would be a problem. It's very common for young women to seek help and think in that first 2 years of menarche that they've got a problem. The most important thing would be to go and see your general practitioner and see if there's any pathology, but usually those first 2 years, that's absolutely normal. It's the first 2 years of starting your cycles, and usually in women who become menopausal, that 3 years before they become menopausal, they end up having irregular cycles. So it's almost the same as the young girl who has irregular cycles at the beginning, and it happens more when they become menopausal as well.
So when you're talking about regularity of cycles, perhaps you can just give us an idea, what kind of regularity should they expect, especially in menarche when they're starting? The older woman at menopause, perhaps by that time she kind of understands that the irregularity will set in. But for a younger lady at the age of 13, 14, what would you say?
Look, the average number of days that young women have their cycles is between 3 to 7 days. If it's more than 10 days, that becomes a problem because it affects their daily living. So sometimes in those cases, just to regulate the cycle, they may need to be put on a pill, or they may need to be given hormones just to stop the bleeding for a while until the cycles settle.
Okay, so when you're talking about the pill and regulating the cycle, obviously we're talking about girls that have not become sexually active and are not married. And I'm sure you get some challenges in this regard as to now why you're putting my daughter onto a pill. What is your response? What's your advice? How do you handle this?
In our Muslim community, it's very difficult to have a young girl who's not sexually active and, they're carrying their pill with them. So it becomes, a problem in the society, because often if another Muslim person sees this young girl with a packet of contraceptives in her bag or, at home, they generally assume that the child is probably sexually active. However, this is not the case. Most of the time, if you find a young girl with a contraceptive, it's just to regulate the cycles, and we try and discuss it with the parents, but it's a very difficult situation.
So do you encounter some anxiety from the younger girl besides the patient about now that the fact that she's going onto a pill? Do you find that to be a problem, or initiating this particular modality of treatment to regulate the cycle, which is very important psychologically and emotionally? How do you deal with that, and is it common?
The common myths that go about is that people feel that the pill causes infertility. It does cause weight gain, but there are lighter pills that are available these days, and there's not much weight gain with the lighter pills. There's also a myth that goes around saying that the pill does cause cancers and certain types of tumors on the cervix, tumors in the uterus. However, this is not true. It's just a myth.
Okay, I know you're saying it's a myth, but there is still a bit of a risk with the pill, right? And maybe you want to elaborate, what kind of risks are there?
The risks in the first year of using the pill is getting deep vein thrombosis or emboli. Emboli are just clots either in your large vessels or even in your small vessels. The risk with getting clots is almost the same in every pill. With the higher doses of estrogen in the pill, the risk is much higher. However, in pregnancy, falling pregnant, your risk for DVTs or clots is much higher. So if you're on the pill for a year, there is a risk of having a clot. However, but if nothing happens within that first year, your risk drops down to almost zero.
And when you're talking about this risk with the pill, you're talking about high dose, low dose. You want to kind of just explain a little bit what is high dose, low dose?
The higher doses of estrogen in the pill used to be 50 micrograms. Now the newer pills have come out with lighter doses, so you get 15 micrograms of estradiol or 30 micrograms of estradiol. Those are the common pills that are now available. In the much older days, 15 to 20 years ago, the only pills that were available were the higher doses of estrogen. However, now the companies have now made pills that are much lighter, but they're still effective as a form of contraceptive, and we use the much lighter pills to regulate cycles. We also counsel patients that with the very light pills, they have to take the pill on time if they are using it for contraceptive purposes. However, if you're using it for regulation of cycles, you can have a 12-hour gap.
Okay, that's now, you just spoke about regulation of cycle, but also at the same time there has to be regulation in terms of taking the pill. Is that correct?
That's correct.
And how do you, in your experience, achieve this? Because we find very commonly when we want to put a particular female onto a pill, a response comes in, you know what, I'm going to forget. So can't you think of something else or do something else for me, but I'm definitely going to forget. So how are you counteracting that, and what kind of advice would you give?
So I always advise my patients, take your pill at bedtime, usually when you brush your teeth, because most of us, brush our teeth, and that's the best time to remember to take the pill. And also, if you take the pill at night, you sleep through the side effects. The side effects such as nausea, breast tenderness, and headaches. And that usually occurs in the first 3 months of starting a pill. And one of the common things that I find in my practice is that young girls often have a brown discharge when they start the pill for the first time. And that causes a lot of anxiety. That is absolutely normal. If you persistently have spotting or a brown discharge in the first 3 months of starting a contraceptive, that's absolutely normal.
So if it's beyond 3 months, 4, 5, 6 months, it continues and they have some spotting, then obviously they should consult you or to their practitioner to see perhaps the dose of the pill is not absolutely correct for that particular person.
Yes. So they may either need something that has a slightly higher dose of estradiol, or maybe a lower dose, or maybe the progestogen is either too low or too high. So each pill is not for every patient. You know, we tailor the type of pill according to the side effect profile and what happens to the patient within that 3 months of starting the pill. So if there's excessive weight gain in the first 3 months, then we often change the pill, or we offer them different options.
And patients that come to you where the pill is now contraindicated, meaning that basically they cannot go on to a pill for certain particular pathologies and diseases they may have, and the common ones that you encounter where you would recommend and rather say, look, you know what, they have to think of an alternative mode of therapy for their particular problem.
There's a whole host of different options available to regulate cycles. For example, you can use a patch. There are hormonal loops that are available. For contraceptive purposes, there's a non-hormonal loop that's also available. Recently, they've come out with an implant that can be put into the arm, and that's for about 3 years for contraception. The other option is the new vaginal ring that has been out in South Africa for about 6 months, and that women can place into their vaginas. It's almost like inserting a tampon. It stays in the vagina for about 3 weeks, and then you get a week break where you remove it so that you have your period. It also has hormones in there, but the side effect profile is completely different to the pill.
And what are the conditions where you would say, look, not the pill, but one of these other options that you have mentioned?
If there's a history of having deep vein thrombosis or any other clotting defect in the patient or in her family, if there's an undiagnosed bleeding disorder that needs to be investigated, obviously we wouldn't prescribe a pill in a pregnant woman. Somebody who doesn't have well-controlled diabetes or uncontrolled hypertension, they should not be on the pill. We can use the pill in smokers and people with well-controlled blood pressures, but after the age of 35, we warn them, to use other options of the pill. Women that turn 40, the risks for deep vein thrombosis and infarcts and ischemic diseases does increase. Therefore, after 40, we use the other options. Well, we offer them the other options.
And what do you do with patients with migraine? Because that's fairly common.
Migraine is not an absolute contraindication for the pill. Migraine with aura is an absolute contraindication with the pill. So we often work together with a neurologist to see what kind of neurological defect there is with the patient. You can use the pill in a patient with simple migraine, but in complex migraine, we don't use the pill.
We will be opening up the line shortly, and just for you to take the number, it's going to be 011 086 7701 or 2 or 3. 011 086 7701 22 011 086 7701 or 2 or 3. So lines will be open shortly. In the meanwhile, what other common conditions would you, for young girls or even females that are coming, in terms of general wellness, female wellness? We've discussed menstrual disorders, the pill. Other things like pap smears, screening for cancers, things like that.
In every sexually active woman, it's very important to have the screening test called the pap smear. So basically with that test, what we do is we do a vaginal examination and we brush on the lining of the cervix and send that off to the lab. And that gives us an idea on the pathology on the cells that sit in that squamocolumnar junction that's within the cervix. Sometimes we find that those cells change shape, and that can be from an infection, or those cells change shape where they can become a cancer. So those kind of cells are pre-cancerous cells. So before they become a cancer, we can offer the patient a laser or just a large loop excision of that zone instead of offering them the hysterectomy or letting it progress to cancer. So cervical cancer, pre-cervical lesions are treatable. So if you have your pap smear annually, it's treatable if we do find these abnormal cells. So it's very important to have your pap and your breast examination by your gynecologist or general practitioner an important thing is also to do your breast exam every month. The best time to examine your breasts is a week after the end of your period. And once you go for your gynae checkups or your checkup at your GP, they can actually show you how to do the breast examination.
Very important screening advice. We'll be taking an ad break just now, and then after that we'll be taking your calls. Just to repeat the number, 011 086 7701 or 2 or 3. And we'll take a short ad break, and then we will join you with your telephone calls. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. Our discussion tonight is on gynecology and issues around gynecology, and perhaps a little bit on obstetrics too, because we have a gynecologist here, Dr. Taheera Hassim. Just before the break, we spoke on various issues like menstrual disorders, the contraceptive pill, very important screening advice like pap smears and mammograms. The lines are open, 011 086 7701 or 2 or 3. Please feel free to call in. Dr. Hassim is here to take your calls. While we're waiting for the call, Taheera, one of the important things I'm sure that you encounter is preconceptual advice. Patients coming in, just recently married, now planning a family. What do you do? What do you suggest? And I'm sure you're encountering quite a bit of that.
Yeah, the most important thing for preconceptual advice is that women should start their folic acid at least 3 months before they plan to conceive, because with folic acid it just prevents babies from getting spinal defects, for example your spina bifida. We also advise them to do a German measles test, which is also known as rubella. If they haven't been immunized, or if they've got a current infection, we don't advise them to fall pregnant during that period of time. And if they haven't been immunized, they should have their vaccines at their GPs and then try and conceive after 3 months.
That's 3 months after the rubella vaccine.
After the rubella vaccine.
So when a patient comes to you and they say, look, we've been exposed to someone with a rash, we're not sure whether that child or that other person that we're in contact with had German measles or chicken pox, but it was some rare type of rash. What's your approach? Because there's a lot of fear and anxiety there. They're planning a baby, a family, and suddenly they've been exposed in an unplanned scenario.
So if they've been exposed within the first 3 months of their pregnancy, it's important to have your rubella bloods done. If the blood result shows that there's a current infection, there's a very high chance that this pregnancy will be affected. There's a 90% chance that the baby could be deaf or blind or have a cardiovascular abnormality. So if they've had their blood test and there's no current infection at that moment, I would advise them to repeat the test within 6 weeks. And if it's still negative, they are safe. If it's positive, then they need to see a fetal medicine specialist.
So during that time, should they then, if they're not sure if they're pregnant and they haven't missed their period, would you then advise on some type of contraceptive or condom use during that period of time?
The first thing would be that they need to exclude a pregnancy, so they should do a pregnancy test and then, yes, maybe use barrier methods until they've got all their results.
What other issues come up when you are consulting from a patient perspective on preconception besides the things you've mentioned? Is there anything else of importance that sometimes comes up to you and you feel that needs the attention of the public at the moment?
Look, we discuss, we take a complete history of the patient. We discuss all their genetic issues. So if there's anybody in the family with cystic fibrosis, if there's a patient who, if the patient has a previous child or a sibling that has Down syndrome, those are the kind of issues that we discuss. So every issue is tailored according to the patient's history. If there's a history of breast cancer or endometrial cancer or anything of that sort, we discuss all of that prior to them falling pregnant so that they've been screened and they're in perfect health before they conceive.
And then once they're pregnant, obviously, then we use the medical terminology, the intrapartum, right? And obviously they come to you, they do the early visits, they go to the GP or to the gynecologist. At what point do you start discussing genetic disorders, amniocentesis, testing and screening for genetic abnormalities? And then obviously leading on to that, what type of action is supposed to be taken if something comes up?
Look, most patients, arrive at the practice between 6 and 8 weeks of missing their period. We do a full general health checkup, scan them to establish how far pregnant they are, and then we discuss the different options of testing. So in terms of genetic testing, if the partner is a carrier of cystic fibrosis, or if there's cystic fibrosis in the family, then we offer them counseling and we send them to the genetics counselor, and they can do their bloods from there. When the most common thing that we do test for is Down syndrome. There's a screening test and there's a diagnostic test. A lot of the patients have this anxiety that when they arrive at the rooms, when we talk about Down syndrome, the first thing that they think about is an amniocentesis. So there's a difference between Down syndrome screening and a difference between Down syndrome testing. So we offer screening, which is a scan. We look at the presence of the baby having a nose bone, and we look for something called the nuchal translucency. The nuchal translucency is just a skin fold behind the baby's neck, and we measure the fluid in that skin fold. At the same time, we take the patient's age and we send her for bloods. All 5 of those parameters will give us an idea as to what her risk profile is. So sometimes you get a result that would say this patient is 1 in 50,000 of having a Down syndrome baby. So although she's at a low risk, she could still be that 1 patient in 50,000 that's carrying a baby with Down syndrome with a false negative result. Or you could have a patient who gets a result 1 in 10 with Down syndrome. And that patient may be 1 in the 10 that's actually carrying a baby that doesn't have Down syndrome. The only way to know for sure whether the baby is affected is to do either an amniocentesis, which is done between 14 and 16 weeks, or a chorionic villus sampling, but that is done less than 8 weeks. There's a high risk of miscarriage with chorionic villus sampling, whereas with amniocentesis, it's about 1 in 200 patients that miscarry from that.
We'll come back to that just now. I just want to see if any callers are coming through. The lines are open, 011 086 7701 or 2 or 3. Dr. Taheera Hassim, gynecologist and obstetrician, is here with us. We're having a very interesting discussion on various issues in gynecology and obstetrics. So please feel free to call in. I repeat, 011 086 7701 or 2 or 3. Coming back to that screening on Down syndrome, Taheera, particular ages, when you've got a particular protocol at which you recommend it highly?
Look, I often recommend that my patients go to a fetal medicine specialist. They offer them Down syndrome screening using a different computer software program. The general gynecologist uses a software program from Lancet. It's far more accurately done with a fetal medicine specialist. And also at the 18 to 23 week scan, the fetal medicine specialist can scan the baby for structural abnormalities. That is not only associated with Down syndrome. So your things like cardiac abnormalities, spinal defects, issues with the baby's kidneys or bladder, even skeletal abnormalities. So they look at the baby from head to toe. That's done at a fetal medicine specialist.
That's a very important message. So it's not just one particular condition we're looking at. It's a head-to-toe thing because abnormalities can occur in many different anatomical areas. And we see a lot of cardiac conditions, valvular disease. So although you may not want to take action, but at least the couple and the parents are then prepared for a baby that may potentially have a problem, and then obviously adapt their lifestyle and have a better preparedness in terms of how they're going to manage their baby. Is that correct?
That's correct, because a lot of the times, if a baby is born with an abnormality and the baby wasn't screened during the antenatal visits, it's very difficult, to have a baby that's born and suddenly the child needs to go to ICU.
Okay, we got our first caller. Sorry to interrupt you, Taheera. It's our first caller. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam, Sidi. Sir, I joined your program later. I'm 43 years old, and I wanted to check that at my age, I've been using contraceptives, Narasterate, and wanted to check Islamically, can I have a hysterectomy, or should I continue because I'm not planning to have any more kids?
Taheera, you want to take that?
The Narasterate is an injectable contraceptive. That's absolutely fine after the age of 40. You don't have to have a hysterectomy just because you don't want to have children. There are also other options that are available, like the loop and a sterilization, which is a permanent form of contraception. And the other option that's also available is a vasectomy, although it's not recommended in Muslims. It is available.
Okay.
Does that answer your question, sister?
Yes, it does, because like I said, it's been 6 years using Narasterate, and because you do it like every second month, it becomes a little bit tiring, heavy to go in now and then. So I was looking at sort of a permanent solution, other than the hysterectomy.
The permanent solution would be, as I said, a sterilization. There's a lot of myths going around where people assume that a sterilization interferes with the hormones and causes excessive bleeding. A sterilization is just ligating the tubes. So it has no effect on the ovarian function or on your cycles. If you've had heavy periods before the sterilization, before the using the Narasterate, you will have heavy periods after stopping the Narasterate. But the sterilization has absolutely no effect on your cycles or your hormones.
Okay, I've not been getting my cycle for, like I said, the 6 years I've been using it. I now and then have hot flashes. I'm not sure whether am I getting that to menopause, or is it linked to the fact that I don't have my cycle at all.
You're not getting your cycle because of the Narasterate, is it right, Taheera?
Yeah.
And if you're getting the hot flushes, then perhaps you can go for a blood test to see maybe you're getting early menopause, or it may be from other reasons. You've got to check your thyroid, your diabetes. So there's many other reasons for hot flushes. So you actually need to have a slightly more comprehensive checkup and perhaps consult your doctor so that they can go through all these issues with you. Jazakallah khair for your question, sister. We've also got a question from another sister, but she's a bit shy to come on the air. She's 52 years old, and she's been on a contraceptive for the last 30 years, and she's still continuing. We don't have more detail on her, whether she's still seeing menstruation and what type of contraceptive she's taking, but Taheera, basically she wants to know what should she do now.
So if she's on the contraceptive pill, as I said earlier, over the age of 40, you can't use the combined contraception. If she's on a progestogen-only pill, that's fine. But at the age of 52, I would stop her and wait for 6 weeks and then do her bloods. If her bloods show that she's menopausal, there's no need for contraception.
Okay, I hope it answers that sister's question. We have another caller. Assalamu alaikum wa rahmatullah.
Assalamu alaikum. Are you Dr. Taheera?
Alhamdulillah, and yourself?
Alhamdulillah. Dr. Taheera, the pill hasn't been working for me for many years. I get very bad headache. So after my second child in February 2012, I got a copper T loop.
Okay.
Which has been working for me fine with regard to no headaches. But I get bleeding for like 10 to 11 days each month.
Okay.
So now what I did is my doctor was giving me various pills to try. For the past 3 weeks, I've been on a pill called Loginon.
Okay.
And it's been working in the sense that it's the first pill that I haven't had a headache.
Okay.
But I've started bleeding early. Like after 3 weeks, before even the white placebo tablets, I've started my period.
Okay. So.
And I've been bleeding for about 6 days. So I'm confused because I was hoping to get into the pills. I could remove the loop and I could have like a regular and not such a long period.
Yeah, look, one of the side effects with the copper loop is a heavier, more painful period. So what you're experiencing is absolutely normal with a copper loop. With your contraceptive pill, the estrogen might be a bit high in that pill. That's why you're bleeding in the 3rd week of your cycle. So I would suggest that you go for something lighter in terms of the estradiol component of it, maybe something with 30 micrograms. The Logenon has 50 micrograms. How old are you?
I'm 30.
Sister, are you still there?
Yes, I'm 30.
30 years old.
Okay, so you'll have to go for something slightly lighter than that.
Okay, because I've tried Yasmin, I've tried Famidine, I've tried some, I think, Triphasal, and everything. I had bad headaches.
Yeah, the estradiol component in those pills is higher than some of the others. I'm not allowed to mention product names, so you'll have to discuss with your gynae for a much lighter pill.
Okay.
So sister, you've got to discuss basically in a nutshell, a lighter pill means a lighter dose of the actual ingredient in the hormone, and then see how it's going to affect your headache and the balance between that and your menstrual cycle. But at the moment, you still got your copper T loop in there. Is that correct? Okay, I hope that answers your question. We have another caller. Assalamu alaikum wa rahmatullah.
Wa alaikum salam.
Sorry, can you speak a bit louder?
I'll try.
Okay, we can hear you.
Good. I have a question for myself personally. It has nothing to do with pregnancy or anything like that. I am 51 years and I am going through menopause, I think, but I don't have severe symptoms because I've read about this and I know how to manage it. So I've worked out all my life to gym 5 times a week, so I don't suffer from flushes or any of the food things. I've never had things. But what is happening is that I don't get period anymore. I think over the last year I've been having my period every 3 months, and I've had a short period which is normally about 4 days. So what is happening now is that I spot, instead of having a sort of normal period, which I consider normal for my 4 days, it spots. So I've started taking a herbal Salal, hormonal balance something, which I'm not sure whether it works for me or not, because I thought maybe it would, balance my hormones, get my period going, but it's been 3 months since I've last had a period.
Okay, sister. Taheera?
Once you enter the climacteric, that's just prior to your period stopping. Menopause means the ending of your period, or your last period. So what you're going through is called the climacteric. So you are going through that phase where your period is gently lightening, and then eventually you have no period. Those products will not bring your period back. Those products that you're talking about is usually for symptomatic relief, like for hot flushes, anxiety during the menopause. If you don't have those symptoms, you don't need to use those products. They will not bring your period back.
Okay, the sister is not on the line now. I hope she's listening to the answer on TV, because her line is quite bad, but I hope that answers your question, sister. We have another caller. Assalamu alaikum.
Wa alaikum salam.
Go ahead with your question.
Doctor, I just wanted to ask you, I'm 40 years old. I'm not sexually active, and I'm on Cipramil. And I bleed quite heavy for about 10 to 12 days. Is it safe for me to take a contraceptive, a mild one?
Yeah, you would be looking at an option of, maybe a patch or a vaginal ring. Have you ever been sexually active?
No, never.
Never. Okay, so then a vaginal ring wouldn't be an option for you. Perhaps a patch or an injectable.
Okay, where can I get that, doctor?
You'll have to go either to your GP or your gynecologist for a prescription.
Okay, Jazakallah.
Okay.
Okay, Jazakallah for the questions, and we'll wait for more calls to come in. There's another call coming through. Assalamu alaikum. Assalamu alaikum. Have we lost that caller? Assalamu alaikum. Are you there, caller? Okay, the lines are 011 086 7701 or 2 or 3. Please feel free to call in as we try and get more callers to call through. Taheera, there was some interesting questions there. Anything you want to latch on to, that particular questions that we're getting? Because it seems all to be relating to either menstrual irregularities in advanced age and menopause, and people sometimes don't know the difference between the climacteric and the menopause. Maybe you want to just touch on that a bit?
Okay, even though women are, 8 to 10 years before they become menopausal, they may have symptoms. So those symptoms of the climacteric are hot flushes, they have severe anxiety, or vaginal dryness. The commonest ones that I see in my rooms are vaginal dryness. A lot of the patients present with recurrent urinary tract infections, and when the patient arrives and you do a urine sample, it's absolutely negative. Most of these women are over 40, and the symptoms are more because of the low estrogen in the vagina, and that gives them, a feeling of an infection, whereas it's just simple vaginal dryness and may require a cream that has estrogen. So these symptoms can start 10 years before your period actually ends.
Very important there. Now, we got another caller, so we'll continue with our discussion with the caller. Assalamu alaikum.
Wa alaikum salam.
You can go ahead with your question.
Okay, my name is Mohammed. I'm a pharmacist by profession. I just wanted to seek Dr. Taheera Hassim's opinion on sometimes I get a lot of cases, our Muslim female folk above the age of 40 coming in and seeking advice regarding prolonging their menstrual cycles, especially during the fasting month of Ramadan, because they want to remain clean so that they can nicely keep their fast. They don't want to keep their fast qaza. Or they can engage in their daily recitations. And I generally don't advise them to do that because of the fear of increased chances of developing deep vein thrombosis or even blood clots. So what is Dr. Taheera's opinion on the Muslim woman prolonging their menstrual cycles or delaying it from happening?
Very good question, Mohammed, and we find it very commonly, not only at your level, but also at our GP level, where patients are going for Hajj and Umrah, and they want to obviously not have a menstrual cycle, especially when they're in Makkah. So we tend to delay the cycle and alter it a bit, Taheera.
Yeah, look, in those cases, in women who are over 40, I wouldn't recommend them delaying their cycles. In women that are less than 40, going on for Hajj or Umrah, and if they need to delay their cycles, we do offer them prolonged contraception or discarding their placebos. But in a woman who's over 40, I would not recommend that.
You want to explain why?
There's a high risk of deep vein thrombosis, and also, there's a risk of endometrial cancers. Women should have their cycles at least 4 times a year, and women over 40 are more predisposed to endometrial cancer, so you definitely would not want to prolong their cycles.
Mohammed, are you still there? Okay, Mohammed is gone. Okay, but I hope it answers his question. A very, very good, important, pertinent question. Jazakallah khair, Mohammed, for your question. Do we have another caller? Okay, Taheera, we were talking about various topics. We've been through various things. One of the common things that we find is girls coming with teenage pimples, acne, and we then try and put them on a pill for that particular reason. Do you tend to do that, or you refer them to dermatologists, and do you get resistance from their parents?
We first try to exclude a common thing in our young girls, polycystic ovarian syndrome. If we don't see any ovarian cysts when we scan them, and we also advise them to have blood tests, if all of those levels are normal, then we refer them to a dermatologist. But if the primary pathology is polycystic ovarian syndrome, then we recommend either a pill or an insulin sensitizing agent like metformin. But that all depends on the endocrine disturbance that we find biochemically.
Okay, perhaps we'll carry on with that polycystic ovarian syndrome. We're going to take an ad break now, so listeners, please stay with us. We'll be gone for an ad break. Please remember the lines will be open, 011 086 7701 or 2 or 3. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. We're having quite an interesting and an interactive discussion today on gynecology and obstetrics. The lines are open and we have our first caller. Assalamu alaikum wa rahmatullah.
Wa alaikum salam wa rahmatullah.
Can you go ahead with your question, sister?
Yeah, my question is for Dr. Taheera.
Go ahead.
Go ahead.
Yeah, I got problem with bleeding.
How old are you?
I'm 33.
Okay. How long are you?
Yeah, I'm bleeding every 2 weeks now, like almost 2 years.
Have you had a baby before?
Yes, I had a baby in Jesus.
How old is your child?
The child is almost 3 years old.
So the problem with your bleeding has started after your baby?
Yes, after a baby, 1 year.
Okay, so you will need to go and have a thorough checkup, for them to make sure that there aren't any fibroids that's causing the bleeding. Also, just to get your cycles regular, you may need to go onto contraception, but you first need to have a full thorough checkup to make sure that there isn't any abnormalities with your uterus or cervix or ovaries.
Are you on a pill, sister?
I just went to the first meal recently last week.
Sorry, say that again?
A first meal, that womb cancer.
Okay, and what was the result?
The result is not normal.
And are you taking any pill or injection for prevention?
Nothing.
So as Dr. Taheera says, you need to go and get another checkup done and then see if there's anything else. Your pap smear is normal, but you've got to look for other things in your womb, and then your doctor will then advise you correctly.
Okay, Jazakallah.
You're welcome. 011 086 7701 or 2 or 3. Those are the numbers. And we have another caller. Assalamu alaikum wa rahmatullahi wa barakatuh. Caller, assalamu alaikum.
Wa alaikum salam.
Can you go ahead with your question?
My question, I'm also a doctor, and I treat a lot of women or female patients in my practice, and I'd like an Islamic perspective on the patch. I'd like to know when the patient puts on the patch and a compulsory ghusl is necessary, how does she now go about this? Does she remove the patch and put it back on, or should she just leave it on because it's for medicinal purposes, or what is the Islamic perspective?
In terms of the patch, we don't recommend it for our Muslim patients because once you remove the patch, the efficacy becomes low, and you can't pray if you haven't made a thorough, a proper ghusl. And in order for the ghusl to be accepted, you'll have to take the patch off, and that's where people fall pregnant. So the patch is not recommended in Muslims.
Okay.
Does it answer your question, sister?
Yes, Jazakallah. Thank you very much, and keep up the good work. Thank you for putting up such an excellent program for all the public. Thank you, Jazakallah.
Jazakallah khair for the compliments, and Jazakallah for the call, and a very, very important question. The lines are open, 011 086 7701 or 2 or 3. And we have another caller. Assalamu alaikum.
Yes.
Hello, assalamu alaikum. Go ahead with your question.
Assalamu alaikum. I just wanted to know, I got a daughter that is Down syndrome. She's 27 years old, and her period is stopped now for around about 3 or 4 months. Is it possible it can happen?
What's your question, sister?
I just wanted to know about the periods that is stopped, a monthly and menstruation stop.
For the last 3 to 4 months.
Yeah.
And she's 27 years old.
Yes, she's 27. She's Down syndrome, you see.
Menstrual abnormalities can occur in Down syndrome patients. Most commonly, they have menorrhagia, which is excessive bleeding. So, you'll have to take just for a basic checkup to make sure that there's no underlying pathology.
Yeah.
Does it answer your question, sister?
Okay, shukran very much.
You're welcome. Jazakallah.
Shukran. Wa alaikum salam.
Taheera, we were talking about polycystic ovaries. We just started that. We took an ad break. We got a few callers. Maybe just a little bit of a recap. And what do you think is important for the public? Or before we continue, we have another caller. Assalamu alaikum.
Wa alaikum salam. Dr. Hassim, I'd just like to find out at what is the latest stage that a lady can travel when she's pregnant?
Well, it depends on the destination, and it also depends on whether her pregnancy is classified as low risk or high risk. In our low risk pregnancies, local travel is absolutely fine. By car up to 32 weeks, by plane up to 36 weeks if the journey is less than 2 hours.
And overseas travel?
Overseas travel depends on the duration of the flight, and it depends also on the flight restrictions. So if you're flying, for example, to Mauritius, you can fly up to 28 weeks. Certain countries that the destination's much longer, it's 24 weeks.
Okay.
And you'll have to have a note from your caregiver, stipulating whether you're a low-risk pregnancy or a high-risk pregnancy. And also the longer flights, you might need to take anticoagulation. Anticoagulation is medication to thin out your blood to prevent you from getting clots from traveling. And if you are flying, lengthy flights, you may have to get pregnancy stockings and also drink lots of water on the flight.
Jazakallah for your call. And then those
Thank
restrictions you were talking about were obviously airline restrictions also, so they have to double check with the airline and the destination, eh?
Yes.
Okay.
And
we got
it also depends on the destination as well. So you wouldn't want to travel to a malaria area when you're pregnant.
Of course. Yeah, so there's risks of the destination, risk of travel, and risk of pregnancy. All those three risks have to be taken into consideration. We have another caller, and that's going to be our last caller. Assalamu alaikum wa rahmatullah.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Go ahead with your question, brother.
Gee, I have a quick question. My wife's pregnant and she insists on fasting on our upcoming Ramadan 1435. I'd just like to know, what is the recommendation with regards to fasting in pregnancy?
In a low-risk pregnancy, fasting is absolutely fine right up to the end. The baby will not be affected. Provided that the mum feels well during the fast. She must have lots of fluids at the time of seri, and she must feel well during the fast. But obviously if she's got underlying medical problems like high blood pressure or diabetes, or she's got a high-risk pregnancy where the fetus is not growing well, we don't recommend fasting.
Jazakallah.
Jazakallah khair for your question. That was the last call for this particular and the lines are now closed. Jazakallah for all the questions that came in the interactive session. Time goes pretty quick, so we cannot take any more calls, but hopefully we'll do another show on this particular topic in the future. And we will now just wrap up. Taheera, we were just going to wrap up a little bit, recommendations, maybe just a quick summary on polycystic, and then we can just wrap up.
Okay, in terms of polycystic ovarian syndrome, the most important thing is weight loss. If you lose 10% of what your body weight was at the time of the diagnosis, within 6 months, you may get cycle regulation, your insulin levels will stabilize, and you may even get rid of those cysts. Sometimes you may need an insulin sensitizer just to get your insulin levels balanced. Because one of the important things that happens during polycystic ovarian syndrome is high insulin levels, and that forces your body to go into an emergency and everything gets stored as fat. So that will set off the cycle, and once your periods are regular, you can stop that and you can maintain your body weight.
Jazakallah khair for that, and I hope that tonight's show was beneficial to all of you. We've discussed menstrual disorders, the pill, and we've discussed polycystic ovaries. We've tried to give a broad overview of gynecological and obstetric problems generally that are common. Obviously, there's a lot more, and those of you that have been advised to go and see your doctors, please go and do so. Taheera, Jazakallah for coming through. Maybe you want to just perhaps add a few more pointers, any other reminders to the public, anything else that probably we haven't touched on?
Just don't forget to have your annual checkups with your gynae.
And then
That's
you're
the
talking
most
about pap
important.
smears and mammograms that are really, really important. And then obviously people with high risk pregnancies, don't forget that don't take your pregnancies lightly. You may have 1 or 2 pregnancies that have been normal, but not every pregnancy is the same. And then we spoke about the screening disorders. So again, it's the last few minutes, seconds of this particular show. Next week we'll be discussing podiatry. It's foot care. Very important topic. It relates to many, many conditions. Your feet give you a kind of a window to other diseases. Diabetes is very important. We'll be discussing that in a few weeks' time. So please join us again next week, same time, same place, for another comprehensive chat on health matters, show that is done by the Islamic Medical Association and the guests that we bring along. And Jazakallah khair for all your time, and the viewers for participating. Assalamu alaikum wa rahmatullahi wa barakatuh.